Good morning. My name is Neera Dahl, and I'm an associate professor of medicine in the section of nephrology at the Yale University School of Medicine. And it's my pleasure today to talk about ADPKD with a focus on the diagnosis, the clinical course, and the health implications for this symposium. These are my conflict of interest disclosures. When we talk about PKD, the first diagnosis is made clinically. So here on the left, I'm showing you a picture of a CT scan of someone who does not have PKD, but does have a few cysts in the kidneys. You can see there's a cyst here and a cyst here, whereas this is someone with PKD. And you can see multiple cysts are in the kidney. So the darker regions here are the cysts. And then in this particular cut, I'm showing you the liver as well, and you can see that there are cysts in the liver as well. So ADPKD is really a clinical diagnosis made on the basis of imaging and made on the basis of the features that are present with the kidney cysts. And it's a systemic disorder, so there can be cysts in the kidney, liver, and in the pancreas. There's potential for bleeding or infection into a cyst. There can be kidney stones or complications due to large kidney sizes. There can be intracranial or cerebral aneurysms, an increased risk of abdominal wall or inguinal hernias, and cardiac disease, which can be both in terms of the effect of high blood pressure and left ventricular hypertrophy, and also with valvular disease such as mitral valve prolapse. And this is just a small, not a complete list of the other systemic features of ADPKD. And if we're thinking of this from a kidney imaging perspective, I found this slide helpful. So if you see someone with multiple cysts, if they're bilateral, that puts you in the ballpark for ADPKD. Depending on whether they're parapelvic, cortical, in diffuse distribution or not will help sort out whether it's truly ADPKD or, in this case, one of the other inherited diseases that can cause bilateral kidney cysts. So here you can see they have VHL listed and tuberous sclerosis listed. Both of these have an increased risk of cancer. Whereas what we're trying to define is this someone with simple cysts, or is this someone truly with a family history of ADPKD who has typical symmetrically bilaterally enlarged kidneys and has ADPKD? The common causes of inherited kidney disease, we'll talk a lot about ADPKD, which is 1 to 500 to 1 to 1,000. And that's distinctly different from the autosomal recessive form of PKD, ARPKD, which is 1 in 20,000, and due to a defect in the PKHD1 gene. And I'll talk a little bit about the diseases that cause autosomal dominant tubulointerstitial kidney disease, which can sometimes present with cysts and could be confused with PKD. And then finally talk about ADPLD, which is probably about 1 in 1,000 in terms of frequency as well, which can cause both kidney and liver cysts and can often be confused with ADPKD. So this is an example of one of my patients. This is an ultrasound image that you're looking at, and this is the kidney. And what you can see in the kidney is there's a cyst here and then a few smaller cysts here. And this patient actually has not PKD, but autosomal dominant tubulointerstitial kidney disease. And this is in an autosomal dominant inheritance associated with progressive loss of renal function, but with a bland urinary sediment, with very little protein in the urine, and with no severe hypertension. So that's a distinct difference with this disease and other forms of kidney disease. With now, this is important, a normal or small sized kidneys by ultrasound, with similar features that might be part of ADPKD, such as nocturia or enuresis due to loss of concentrating ability. And if these folks get a kidney biopsy, you may see fairly nonspecific findings such as interstitial fibrosis or tubular atrophy. So autosomal dominant tubulointerstitial kidney disease. And there are 4 gene defects that can cause this particular kind of kidney disease. I think the most common one that we are seeing clinically is the HNF1 beta, but there are different gene syndromes based on the mutation type. And that is distinctly different from ADPKD, where what we're seeing is someone with normal or relatively normal kidneys at an early age, but over time the kidneys get larger and the cysts get larger. And as this is occurring, there's loss of the vasculature. So you can see there's simplification of the vasculature with time and sort of pruning of some of the branches of the blood vessels as those areas become ischemic. There's normal kidney function and then hyperfiltration, and finally impairment of renal function and renal failure. And at the same time these are occurring, there's the development of hypertension, of pain due to the enlarging cysts. There can be proteinuria, sometimes significant proteinuria, and the patients may be aware of episodes of pain due to cyst rupture, may notice blood in the urine, have a cyst infection, have kidney stones, or have urinary tract infections. So when we are diagnosing ADPKD in the clinic, we first look and see, is this someone who has bilateral kidney cysts? And if the answer is yes, then we look at the family history next. If there is a family history and the person has typical imaging for their age, which is a certain number of cysts in either one or both kidney, depending on the age, then we're confident in making that diagnosis of PKD. If they have a family history but have atypical imaging, that might be a reason to consider genetic analysis, because in particular, we know that there are a lot of mimickers of things that can cause both kidney and liver cysts that may not be ADPKD. And here is a nice list of some of those other genes that may be implicated. So we looked at the genes causing ADPKD. The other ones here are the genes that cause ADPLD, the polycystic liver disease, and then a few others listed here. And also important to think about are patients who have PKHD1 mutations, but may present at an older age because they have a relatively mild mutation. And for patients without a family history, this is equally important. It may be reasonable to consider genetic analysis up front to see if they really truly have a mutation in either PKD1 or PKD2. And the screening is similar for children. So if we look at what the guidelines are for screening for children, for screening for genetic disease in children, if there's a treatment decision that can be made if the screen is positive, then it's reasonable to consider screening in the childhood age. So if you have an asymptomatic child with a positive family history, you would discuss the pros and cons of asymptomatic testing with the parents. And then if the decision is made to pursue diagnostic testing, that could be either with ultrasound screening using the guidelines developed for that for diagnosing ADPKD. And in the case of a child, greater than 1 cyst would be enough to diagnose ADPKD with the appropriate family history, or you could consider genetic screening. What is important, though, is the regular follow-up. So checking for symptoms, particularly measuring blood pressure, giving some dietary and lifestyle advice for patients that may have ADPKD. And then to consider how this may impact other psychosocial issues or impact other siblings. If there's an incidental renal cyst found on ultrasound in a child, then the first question to ask is there a family history of kidney cysts? And if there is, that may be sufficient to diagnose ADPKD and then to follow them as you would any other child with ADPKD. If there's no family history, then that would be a reason for genetic testing. And here in particular for the children, what we're following is there hypertension and or proteinuria in the kids who are at risk? And if there is, then they would benefit from treatment of the blood pressure, of the high blood pressure with RAS inhibition and with particular targets aimed at limiting end organ damage from the hypertension. The diagnosis is harder to make in patients without a family history of ADPKD, and there's an arbitrary diagnosis that's in the community, which is it must be at least 10 cysts per kidney. So it's a pretty high bar to meet if there's no family history. And what complicates this decision-making is that cysts are increasing with age. So you can see in this particular chart, someone who's between the age of 50 to 70, about 10% or 12% may have one cyst and 4% may have bilateral cysts. So particularly as patients get older, the challenge becomes to decide, is this truly ADPKD, perhaps with a hypomorphic presentation, or is it someone who has simple cysts as a consequence of aging that have no clinical significance? So here I'm presenting to you a patient who's one of my patients who is at high risk of loss of renal function. He's a 23-year-old man and he has ADPKD. He had early onset hypertension and a urologic event. He had gross hematuria as a teenager. His father had ADPKD and underwent a transplant at the age of 49. The patient has normal renal function. He has hypertension that's well controlled on an angiotensin receptor blocker. And here what I'm showing you is a coronal image of a T2 weighted image of his MRI. And you can see the kidneys nicely outlined here. And the cysts that are present here are in the bright white. And his kidney volumes are given here. So the right kidney volume is 530, the left 594. This gives us a height-adjusted total kidney volume of 661 ml per meter, which is a Mayo classification of 1E. And the other way of assessing risk is by looking at something called the pro-PKD score. So given this family history, he's likely to have a severe PKD1 mutation, and that would give him a high pro-PKD score. So how do we determine who's at risk of rapid progression in ADPKD? And this is a paper that just recently came out from the Mayo, from their analysis of their database. And they said, we will define rapid progression as someone reaching kidney failure by the age of 62. And overall, about 70% of patients with ADPKD will develop end-stage renal disease. So they're saying, they're looking at their patient base and saying about 75% of them developed end-stage renal disease by the age of 62. And so they're saying people in this risk category are those high-risk people. And these are people with Mayo imaging class 1, which means typical bilaterally enlarged cystic kidneys with large kidneys, either C, D, or E kidneys, who have evidence of rapid progression either by a rapid change in total kidney volume or a rapid decline in total kidney function. And then there are other factors that are suggestive of rapid progression. So like in the patient I showed you, onset of end-stage renal disease before the age of 55 is associated with a PKD1 mutation. And PKD1 mutations generally progress to end-stage renal disease faster than PKD2 mutations. And then there can be some clinical features, so hypertension before the age of 35 or a urologic event before the age of 35 is associated with an increased rate of progression. And then this is often one that's very, very helpful to use from the CRISP data, saying that a young patient with a kidney ultrasound length greater than 16.5 is also at high risk of progression and loss of renal function. And this is just showing these risk factors. So these are factors affecting disease severity. And we'll talk more about the differences between the PKD1 and PKD2 mutations. There can be some epigenetic phenomenon. We know that environmental factors are important. So we counsel patients to have good fluid intake, to have low salt intake, and to try and maintain appropriate caloric intake and BMI, because all of these can be associated with an increased risk of progression. All of these eventually lead to a state in which vasopressin is elevated, and this triggers increased cyst growth and increased cell proliferation, inflammation, fibrosis, and endothelial dysfunction. And something that's really being better understood more recently is the metabolic dysfunction that's part of ADPKD. Some biomarkers that help us assess disease severity. So we talked about early hypertension or an early urologic event, of an imaging classification. The larger the kidneys at a younger age, the larger the risk of progression. And then some biochemical features. So looking at the rate of eGFR decline, obviously someone who's declining rapidly is at high risk of loss of renal function. Proteinuria or albuminuria are markers, MCP, urinary MCP, urine osmolarity, and then some novel biomarkers. In terms of looking at other pediatric risk factors for progression, about 2 to 5% of all ADPKD is diagnosed in childhood, and the presentation can really be quite variable. It may be severe with neonatal presentation and mimic ARPKD with a child born or a perinatal observation of bilaterally enlarged kidneys, or it could be an incidental discovery of kidney cysts on imaging later in life. And what's important to note is 35% of children with ADPKD will have hypertension. So it's really important to screen for hypertension. There are genetic predictors. So these are the same as predictors of progression for adults. A truncating PKD1 mutation is associated with earlier onset progression than a non-truncating PKD1 mutation or a PKD2 mutation. There are some cases of very early onset of disease, and there's been a lot of focus on who are the children who have this very early onset, and particularly if that's different from the disease that's seen in the family in terms of age of onset. And some interesting genetic information is emerging from this, in that it could be that there's co-inheritance of two alleles, one that's hypomorphic and one that's inactivating, or two hypomorphic alleles, or co-inheritance of PKD1 or PKD2 mutation with another gene that causes kidney cysts, such as the HNF1 beta or PKHD1. The clinical predictors in kids are the age at presentation. So the younger the age of presentation, the more severe the disease. The presence of glomerular hyperfiltration. So hyperfiltration in kids is that early sign that there's progression of disease, a decreased urinary concentrating ability, gross hematuria, microalbuminuria, overt proteinuria, or the presence of oxidative stress or vascular dysfunction. And I talked a lot about the Pro-PKD score. So the Pro-PKD score is a score that was developed in Western France, looking at a population of the ADPKD patients there. And they basically looked at the genotypes, at clinical information, and came up with a prognostic score for who's most likely to progress. And the way this is set up, if you are male, you get 1 point. If you have hypertension before the age of 35 or a urologic event before the age of 35, that gives you 2 points. And then depending on genotype, you get 0 to 4 points, with a PKD1 truncating mutation being the most severe. And what that then gives you is a score. So people who are at low risk may have a score of 0 to 3, versus those people that are at high risk would have a score of 7 to 9. The patient that I showed you, I thought would be in this category where he was at risk for end-stage renal disease before the age of 49, before the age of 50, whereas those people at intermediate risk develop end-stage kidney disease at the age of 57, and those people at low risk still develop end-stage kidney disease, but at a much later age, in their 70s. The other risk classification score is the Mayo Imaging Classification, and this was developed using both the Mayo database and the CRISP cohort. And basically, there are some inputs that get put into this calculator. So what gets put in is the height of the patient, the age, the gender, the race, and some orthogonal dimensions, so the depth, length, and width of the kidney. And what is given, what's calculated, is the total kidney volume, the height-adjusted total kidney volume, an imaging classification, and then some future eGFR approximations. So this is what it looks like. These are the various measurements that are required. So a width, depth, and the coronal length and sagittal length. And these then get put in. And sometimes when I'm in clinic, I just have a little app on my phone that I can use to do the same type of calculation. And what it gives you is this. So it gives you an imaging classification. So those patients who have large kidneys at a younger age have the higher classification. So 1E in this case being higher risk than 1A. And you can see this is someone with 1E kidneys, so very, very large kidneys compared to someone with 1A kidneys. And in the 1A kidneys, what you see is there's still a lot of normal looking, or that dark looking kidney tissue still present, whereas you really don't see that in the 1C and 1E kidneys. And this correlates to rate of loss of kidney function. So those folks who are class A, the lowest risk category, don't really have significant loss of kidney function until they're in their 50s and 60s. Whereas these three groups, which are the higher risk groups, you can see the class E patients are already starting to show significant loss of renal function in their 30s and 40s. So this imaging classification is really helpful in predicting loss of when loss of kidney function is likely to occur. And what we're doing when we're seeing patients in clinic is trying to assign a risk categorization. So is this someone who has ADPKD, who has large kidneys, and a relatively low GFR for their age, and these are the folks who are then at highest risk, versus is this someone who has small kidneys and maybe has loss of GFR, but it's due to a disease like ADPKD rather than ADPKD, versus is this someone with ADPKD with the typical imaging and the mutation type that's consistent with PKD, but they have class 1A or class 2A kidneys, in which case their risk of progression is quite low. And here, for us, the factors that are important in terms of managing the adult patients, blood pressure control is absolutely critical. We talked about salt restriction and increasing hydration and maintaining BMI and caloric intake at appropriate levels. And then those patients who have typical imaging who are at high risk are also candidates for Tolvaptan therapy. And here is, there are a lot of different prognostic or modeling predictions for how people do with Tolvaptan therapy in terms of the benefit in years free from end-stage kidney disease. So what this is a breakdown of patients by their different CKD stage and then also by their different Mayo imaging classification stage, and guess or estimating the years of benefit of Tolvaptan therapy. And so for someone who has CKD stage 1, their time to ESRD may be 20 years, and they would gain about 5 years with use of Tolvaptan. So that could be a significant difference if that's the difference between when someone is pre-retirement versus post-retirement. Those could be significant age difference or significant benefits in terms of years gained. I think one thing that I've noticed in all of the prognostic calculators like this is that the 1C patients tend to be the ones that have the most benefit. And the way I understand this is these are the folks that are progressing the most slowly in terms of loss of kidney function. They're high risk, but in that high risk category, at the lower end of that high risk. And so something that has a small benefit in terms of slowing down that rate is going to be seen in those people that are moving relatively slowly. Anyway, I think that is something to see if that really is what the data bears out, but it's at least an interesting hypothesis from this kind of modeling. I'm going to switch gears now and not talk about kidney issues so much, but talk about extrarenal manifestations of ADPKD. So the ones we worry about the most, intracranial aneurysms and screening for intracranial aneurysms. I'll talk about liver cysts and some of the cardiac manifestations. And then there are other ones that can occur. So bronchiectasis is more common, seminal cysts and infertility in men, pancreatic cysts, and abdominal wall hernias. So to introduce the idea of liver cysts, I'm showing you one of my patients. She's a 62-year-old woman who has a total kidney volume that's quite large, over 3 liters. But what's really, really even more impressive is this, which is her total liver volume. So a typical liver is about 1 liter, and hers is about 9 times that at 8.9 liters. And she has significant loss of kidney function. So what I'm showing you here is her liver. So this cross-sectional analysis, all of the white spheres, those are all cysts in the liver. And then here you can see a cut. This is the liver, and then these are her kidneys, which are also quite cystic. And she is thin. She has a distended abdomen. Her liver cysts are easily palpable. And in the right upper quadrant and epigastric areas. And she's asking about what's available for her. So a couple of things to keep in mind. Liver cysts are very common in ADPKD, but not everyone develops that severe organomegaly. It's also common to have liver function abnormalities in ADPKD. And so this is looking at this. This is looking at the baseline data of 153 patients who were studied for treatment for liver cysts. And what they saw was that bilirubin, alkaline phosphatase, or GGT, may be elevated at baseline. And the cysts are formed from bile duct epithelium, so it makes sense that markers of the bile ducts could be a little bit off. And I think in our practice, ALT, AST may also, there may be minor abnormalities there or an amylase. And a couple of things that I thought were interesting. So CA19-9 may be elevated in up to 45% of patients. It doesn't mean that there's evidence of malignancy. And in PKD, liver synthetic function remains intact. So the complications with liver cysts are all really due to size. And here you can see what folks are complaining of with liver cysts. So back pain, flank pain, abdominal fullness, right upper quadrant pain, a loss of appetite or anorexia, palpable mass, early satiety, nausea, vomiting. And then things that could happen, so hernias, cyst infections, biliary dilatation or inflammation of the bile tract, cholangitis, cyst rupture, so other complications. And here what I'm showing you is just what some of those different images might look like. So here's someone who has one dominant cyst and another smaller cyst. Here's someone with a grouping of cysts in one lobe of the liver. And then someone with more diffuse disease, and then someone with complete diffuse disease. And really the treatment depends on what the imaging looks like. So if you see someone with a single dominant cyst, then you might consider cyst aspiration or sclerosis. The rest of the liver looks very, very healthy and good. Someone who, in this case, has cysts that are predominantly on the right side, they might undergo a partial hepatectomy. So in this case, of the right lobe of the liver, so to take out that cystic part of the liver. And someone who has diffuse cysts, where the entire thing is full of cysts, really the only option is to go to liver transplant. And so this might be an algorithm for considering how to treat people who have symptomatic liver cysts. So you would first consider aspiration or sclerotherapy, and then perhaps laparoscopic fenestration. And then if there's really an impaired quality of life, to consider liver transplantation. And if that is not an option, then to consider treatment for things like the somatostatin analogs, particularly in highly symptomatic patients. And this is, I'm going quickly, but just showing you the pooled data from 3 trials with the somatostatin analogs. And the take-home points from this pooled data was that the therapy might be the most effective in young women, and that an elevated alkaline phosphatase at baseline may predict who's likely to respond to therapy. And that some suggest, so on somatostatin, for most patients, there's a decrease in growth of the liver cyst size. And once the drug is stopped, the liver cyst growth resumes, but there may be some lasting benefit. And this is an expensive medication with a fair number of side effects. And so if there's no improvement after 6 months, the recommendation is to stop therapy at that point. But this is for symptomatic treatment. The next point to consider is cerebral aneurysms in ADPKD. So we know that for all comers with ADPKD, the incidence of aneurysms is about 10 to 12%. And most of these are in the anterior circulation. And the risk of rupture is greater for those in the posterior circulation. And here I'm just showing you a picture of an angiogram of the brain, and you can see this little outpouching, which is the aneurysm. So if we look at the prevalence of intracranial aneurysms, these are a few different studies, and this was put together in a nice review paper that came out recently. And what you can see is the rate of aneurysms varies here from 9.3% for the lowest to 14% for the highest. And that most of these were in the anterior circulation. And most of them were were small. Some of the aneurysms were large, but most of the ones that were found were fairly small. And then there was a small minority of people that had multiple intracranial aneurysms. A couple of things to point out. So the age at which these aneurysms are found is much younger than the age at which aneurysms are found in the general population. So the prevalence of intracranial aneurysms in the general population is about 3%. Without a family history, the incidence of intracranial aneurysm is lower. With a family history, it's about 23% may have an intracranial aneurysm. So who should get screened? The people clearly with a family history of stroke or a family history of intracranial aneurysm should get screened. If there's a history of a prior intracranial rupture, they should get screened. If they're in a high-risk occupation, such as being a pilot, that might be a reason for screening, or if they're in anticipation of high-risk surgery. And the screening is that we've been using is an MR angiogram, which is without contrast, time of flight imaging. And who to screen, how often to screen, I think those are areas of true debate still. I put up here update slide because I meant to update it, but the practice is our practice is at least to have that discussion with everybody about the risks and benefits of screening and to offer it to all of our patients with ADPKD regardless of family history. And then in terms of when to rescreen, there's a paper showing that cost effectiveness of rescreening was to screen all comers and then to screen every 5 years. And that's distinctly different from some of the recommendations in the literature. And so that is an area of just a conversation with patients. And that's what I wanted to put here is that, that my practice is really to offer that universal screening with follow-up annually if an aneurysm is detected, and rescreening, at least a conversation about it every 5 years if there was no aneurysm detected. And this is important from managing patients, and it's just showing that with time on dialysis, there's an increased risk of intracranial aneurysms that seems higher in the PKD cohort compared to the non-PKD cohort. Important because we tend to give a lot of heparin at dialysis, and so maybe to consider screening if they haven't had it already before they go on dialysis, if they're going on dialysis. And these are just different approaches to treating the intracranial aneurysm, whether it's stenting or clipping or coiling. And this is just looking at those patients who had ruptured intracranial aneurysms. In general, they were young. About half of them had a normal kidney function, and about 2/3 of them had hypertension. And there's an increased risk of rupture if the intracranial aneurysm was greater than 6 millimeters, although there was some rupture at very small sizes. And there are other vascular abnormalities associated with ADPKD. So there's this question of whether aortic aneurysms are associated with ADPKD with a little bit of discrepancy. There's old data saying 10% of patients had an AAA, whereas in the more recent look at that, they didn't find an increased incidence with ADPKD. This is a paper where they found evidence of a coronary artery aneurysm. I think any large vessel could potentially could be aneurysmal, and so worth at least remembering. in our practice, we've seen a few patients, particularly as they're coming up to dialysis, who have a finding of a widened aortic root, and so sometimes that's an implication for before they go to transplant. And we know that hypertension can occur early in ADPKD, and there's some older data saying that LVH, left ventricular hypertrophy, or thickening of the ventricle wall, happens sometimes before the onset of hypertension in ADPKD. And I think that our thinking about LVH has changed somewhat with the widespread use of ACE inhibitors and angiotensin receptor blockers. And this is just looking at the incidence of left ventricular hypertrophy in the HALT PKD cohort. And the very good news here is that the prevalence of LVH was relatively low, so about 4% when it was measured in one measurement by cardiac MRI, and then even lower when a different measurement was used. And about 60% of the patients in HALT PKD were on an ACE inhibitor or an ARB prior to study enrollment. There can be other cardiac abnormalities, so mitral valve prolapse, tricuspid prolapse, and aortic valvular abnormalities. And then other possible cardiac abnormalities, I think there's a lot of interest in whether PKD2 mutations can be associated with a dilated cardiomyopathy. There's some other sort of increase, like case report level things that have been described, heart abnormalities with ADPKD. And this paper that came out a few years ago suggesting that there was a higher incidence of atrial fibrillation, a very common irregular rhythm in our patients that may be more common in ADPKD patients. And as a nephrologist, what I'm looking at when I see a patient is I'm going over this entire spectrum of ADPKD care. So starting with diagnosis and then basic management and self-care guidelines, talking about prognosis. So that's a really big part of that initial visit, is trying to determine prognosis. And then managing the issues as they come up. So as kidney function declines, or as some of these other non-renal issues emerge, if there are questions around family planning or counseling around pre-implantation genetic diagnosis, that's part of the visit as well. And then talking to patients about how this will affect where they are in terms of life planning and things like that. And then obviously talking a lot about preparing for dialysis or transplantation. So that's my talk, and thank you very much. And I'm looking forward to the live presentation.